Madam G, a 42-year-old nurse with active rheumatoid arthritis, has lab work indicating a systemic vasculitis. Suddenly, the waveform of her hearing changes. She presents with a severe, rapid loss of hearing that began in her right ear 4 months ago. Clinicians initially treated the right ear as standard sudden sensorineural hearing loss. A course of steroids provided a mild initial improvement. Exactly 6 weeks after the right ear began to fail, her left ear began an identical, rapid decline. This was accompanied by bilateral tinnitus, aural fullness, and intermittent episodes of mild vertigo, occurring between the acute drops in hearing. Despite the severity of her symptoms, the physical exam is unremarkable. Otoscopy shows normal tympanic membranes in clean canals, and she has no history of noise exposure or otoxic drugs. A staggered bilateral hearing loss in a patient with an active systemic autoimmune background is a massive red flag. This specific presentation requires immediate differentiation from standard otologic pathologies. The timeline immediately rules out presbycusis, which typically degrades hearing over decades. The successive nature of the attacks also rules out a standard vestibular schwannoma, which is almost always unilateral. The target diagnosis is Autoimmune Inner Ear Disease, or AIED. AIED represents a unique overlap where systemic rheumatology breaches the isolated structures of the ear, requiring a hybrid diagnostic approach. To manage this condition, we have to map its unique temporal speed and identify the cellular breach of the inner ear, and determine why the definitive test relies on a functional response. Because this progression happens quickly, the window to recognize the staggered decline is narrow. Missing it often leads to irreversible neural destruction. The patient's pure tone audiometry confirms a profound sensorineural hearing loss, with the most significant data found in the timeline of the decline. This graph tracks decibel loss against a 4-month timeline to define rapidly progressive loss. Within 3 months, the right ear drops by over 30 decibels. The left ear remains stable until the 6-week mark, then follows an identical downward trajectory. This specific pattern, bilateral, asymmetric, and rapidly progressive over weeks or months, is the cardinal sign of the disease. Simultaneous bilateral loss is exceptionally rare. The 6-week temporal delay seen here is the classic hallmark of AIED. The audiogram proves the destruction is rapid and bilateral, but it does not explain how a systemic immune disease reaches these isolated structures. Normally, the cochlea is an immune-privileged site, protected by local immunosuppressive factors. The primary shield is the blood-labyrinth barrier within the stria vascularis. Systemic diseases like rheumatoid arthritis rupture this tolerance. Autoreactive elements cross the compromised barrier into the inner ear. Inside, they attack cochlear antigens, like heat shock protein 70 and collagen type 11. This immune reaction triggers localized endolabyrinthitis and vasculitis of the small cochlear vessels. The resulting cochlear neuritis destroys hair cells and nerve fibers, leading to the sensorineural loss seen on the audiogram. Understanding this active inflammatory destruction dictates what we look for on imaging and what we must rule out. A cochlear MRI confirms the active inflammation predicted by the pathophysiology. Bilateral gadolinium enhancement in the cochlea and nerve confirms inflammation while ruling out a structural mass like a schwannoma. Because AIED is a diagnosis of exclusion, it must be separated from 3 major clinical mimics. The first mimic is bilateral Ménière's disease, which involves fluctuating loss and prolonged vertigo. Unlike AIED, Ménière's progresses slowly and responds to diuretics and beta-histine rather than immunosuppressants. The second mimic is otic syphilis, which causes progressive bilateral loss but presents with positive TPHA or VDRL serology. The third is Cogan syndrome, which requires an ophthalmological exam to check for interstitial keratitis and uveitis. Once imaging rules out masses and systemic testing rules out syphilis, the clinician is left with an active autoimmune profile and one final diagnostic hurdle. There is a common clinical trap in searching for a single definitive blood test for AIED. While markers like ANA and ANCA point to systemic disease, and Western blot tests for HSP70 exist, they are non-standardized and controversial. There is no definitive serum test for this condition. The diagnosis depends on the patient's clinical response. An empiric corticosteroid trial serves as both the diagnostic confirmation and the first-line therapy. The protocol involves high-dose systemic prednisone at 1 mg per kilogram per day for 4 weeks. If the patient shows a 15 decibel improvement in hearing threshold by week 4, the functional diagnosis is positive. This 15 decibel gain proves that the hearing loss was driven by active, reversible inflammation. Because the treatment itself is the test, clinicians must not delay the steroid trial while waiting for lab results. Early intervention is required to rescue viable nerve fibers. Many patients relapse when the high-dose prednisone is tapered, leading to steroid dependence. To maintain hearing gains, clinicians transition patients to background immunosuppressants like methotrexate. In severe cases linked to ANCA-vasculitis, more aggressive targeted therapies like cyclophosphamide or rituximab are proven to be highly effective. If medical therapy fails and results in profound deafness, a cochlear implant is indicated. Outcomes for these implants vary in AIED patients due to the localized neural destruction caused by the immune attack. To recognize this disease, use the RAPID framework: rapidly progressive loss, autoimmune background, progressive bilateral decline, immunosuppression as treatment, and distinguishing it from mimics. By recognizing the rapid bilateral decline and initiating the steroid trial immediately, clinicians can halt the immune system before it destroys the patient's final connection to the auditory world.